Welcome back to the deep dive. You know, when we talk about complex anatomical structures in orthopedics, especially the knee, the classification system we use, it isn't just some administrative checkbox.
Not at all. It's the operational map. It is the absolute blueprint for everything that follows.
Exactly. If we misclassify an injury, if we fail to accurately name what's broken, we're basically setting that patient up for chronic instability, for, failure.
The whole point. And today we are taking a really definitive surgical deep dive into this, into classifying knee ligament injuries. We're basing this on a fantastic review by Collins, Radnay, Hodgnick, Scuderi, and Scott.
Right.
And their central argument is, well, it's something we all know in the OR but needs to be said. We have to adopt a standardized, valid, reproducible, and just universally accepted classification system.
So our mission today really is to lay out that blueprint. As a resident, I see the sheer volume of literature out there, but as the authors argue, if we don't all agree on the terms, if my description of abnormal knee kinematics is different from yours.
It's ambiguous. It's useless.
It's totally ambiguous.
Think of it like this. The knee's stability is like a complex air traffic control system, over a major airport.
Okay.
If every pilot uses their own proprietary language to describe their flight path, or every tower calls the same runway a different name, you get chaos. You get kinetic chaos.
I love that analogy. Kinetic chaos. That's exactly what residual instability is.
It is. Our classification system has to be the universal language. It has to connect your clinical exam, what we see in the operating room, and what the anatomical studies tell us seamlessly. If those three things don't line up because of bad terminology, we can't do our jobs.
So it's about moving from just, it's a grade 2 tear, to an objective map of mechanical failure. We need to know which roads are closed, which bridges are out.
Precisely, which roads are closed. Because an injury rarely happens in just one plane. The knee moves in 6 degrees of freedom. If your language can't handle those coupled motions, you're going to miss the very thing that keeps an athlete from being able to pivot.
All right, so let's unpack this. Let's start on the medial side. I mean, that's where so many traumatic forces start their damage.
It's the first line of defense, often. The foundational work here, you have to go back to Houston and Warren and Marshall. They really set the standard for understanding the MCL and the posterior oblique ligament, the POL.
And the big player on that side is the superficial MCL, the SMCL.
That's the fortress wall. It is the primary static restraint. I mean, it's a main thing resisting valgus stress, the knee buckling inwards across the entire arc of motion. Robinson's work really confirmed that quantitatively.
And the biomechanics of it are just so elegant. The way it maintains tension almost no matter the flexion angle.
It's brilliant biological engineering. Brantigan and Voschel described it years ago. You have these vertical anterior fibers of the SMCL. They're arranged around the axis of flexion, so their tension stays pretty constant.
We're always on guard.
Always. But then you have the oblique posterior fibers. They're different. They blend in with the deeper layers, and they actually relax as the knee goes into deep flexion.
Which is fascinating. So even as part of the structure is relaxing, the main body is still holding strong against that valgus force.
That's the design. But, the posterior medial corner,
right?
That's where the complexity really ramps up. It's so much more than just a deep capsular layer.
And Griffith's work helped us dissect that, right?
Yeah.
Functionally.
Yeah.
Show that different parts of the MCL complex do different jobs.
Exactly. We learned that while the whole SMCL handles valgus, it's the proximal division of the SMCL that's really the key stabilizer to valgus throughout the motion.
And the distal division, the part that inserts way down on the tibia, that's more about rotation.
Correct. The distal division is the primary stabilizer against external rotation, and its role is biggest when the knee is flexed at 30 degrees, a common position for injury and for our clinical tests.
And then you have the posterior oblique ligament itself, the POL.
Right. The POL takes over when the knee is near extension and you get an internal rotation force. It coordinates with the semimembranosus tendon. So you see, depending on the angle and the rotation, the knee is dynamically shifting stress between these different medial structures.
Which is absolutely critical for our repair strategy.
Yeah.
But this is where Laprade's reevaluation was such a game changer. He really challenged that old, oversimplified, layered approach we all learned.
He did, because that layered model was leading surgeons to be inaccurate by several millimeters, and in ligament tensioning, millimeters are miles.
A few millimeters off, and your graft is either too tight or too loose.
Right. It was a good descriptive tool for a dissection lab, but it was a terrible topographical map for placing a graft. LaPrade brought in quantitative anatomy. He gave us coordinates.
And he identified that third bony prominence, the one that was so often overlooked.
Yes, the gastrocnemius tubercle. This finding, it completely refocused everything. This little bump is distal and posterior to the adductor tubercle, right where the medial head of the gastroc attaches.
Why is that one landmark so critical?
Because the femoral attachment of the POL, the ligament you absolutely have to reconstruct to get rotational stability back, is much closer to this newly described gastrocnemius tubercle than it is to the adductor tubercle, which was the old landmark.
So if a surgeon is still using that old description and they target the adductor tubercle for their POL graft, what happens?
You invite failure, either stiffness or continued instability. If you put that tunnel a few millimeters too anterior, the graft won't be isometric. It might get super tight in early flexion so the patient can't extend fully, or it'll be loose in extension right when you need it to resist internal rotation.
So it's the difference between success and a revision.
It's everything. You have to replicate the exact biomechanics. That micro detail is non-negotiable.
Okay, let's move centrally. Let's anchor this with the cruciates. The ACL is, of course, the one we deal with most often. It's that primary check rein against anterior tibial displacement.
And when we're in surgery planning our tunnels, every millimeter is guided by landmarks. On the femur, we're always looking for that bony ridge on the medial wall of the lateral femoral condyle.
The residence ridge.
The residence ridge. It's the do not cross line. It serves as the anterior border of the ACL's footprint, so we know we have to place our tunnel posterior to it.
But the ACL isn't just one single rope. It's a continuum of fibers, which led to the work by Gerges and then Amos and Dawkins, who broke it down into the two functional bundles.
The anteromedial, or AM, and the posterolateral, or PL, bundles. And understanding the kinematic dance between these two is vital. They are absolutely not isometric.
Right. The AM bundle tightens in flexion.
It tightens and lengthens as the knee flexes. It's maximal at 90 degrees. The PL bundle is the opposite. It shortens in flexion and is taut primarily in extension. This is how the ACL provides restraint through the entire range of motion.
And that behavior directly explains our clinical exam findings, which is the key for classification. If you have an isolated AM bundle tear,
which is a common partial tear pattern.
Since that bundle is tightest in flexion, you're going to see that show up most on the anterior drawer test, which we do at 90 degrees.
That's the clean distinction. Whereas an isolated tear of the PL bundle, that's going to make your Ligament test more positive because you do that at 30 degrees of flexion, right where the PL bundle is supposed to be taut.
Makes perfect sense. Now let's talk about its bigger, stronger brother, the fundamental stabilizer, the PCL. Houston called it the axis of knee rotation.
If the ACL is the emergency brake, the PCL is the load-bearing foundation, the cross-sectional area, the tensile strength. It's just massive. Kennedy and James showed it's almost twice as strong as the ACL.
Twice as strong. So the force required to rupture it must be incredible.
It is. We're talking about forces upwards of 3,000 newtons in some studies. This is why PCL tears, like a dashboard injury or a fall directly onto a flexed knee, are so often associated with other ligament injuries. The energy involved is just immense.
And its function is just as massive. It provides 95% of the resistance to posterior translation.
At all angles of flexion. And Golahan's work showed us that the most posterior translation you get after cutting the PCL is between 75 and 90 degrees of flexion. That's our target zone for clinical testing.
And we can't forget the little helpers, the meniscofemoral ligaments that run with the PCL.
The ligament of Humphrey and the ligament of Risberg, yes. They're crucial secondary stabilizers. Clancy pointed out that in a PCL-deficient knee, they can carry a significant amount of the posterior load, sometimes up to 28%.
Which might explain why some patients with isolated PCL tears can actually function surprisingly well.
It's one of the reasons, absolutely. It's a point we should definitely come back to.
Okay, let's complete the ring of stability, the lateral side. The LCL, the lateral collateral ligament, is the big static support against varus stress. But just like the medial side, the real complexity is in the corner.
The posterolateral corner, the PLC, and it's not just one thing. It's a critical trifecta of static restraints. The LCL, the popliteus aponeurosis, and the absolutely crucial popliteofibular ligament, the PFL.
The PFL is so important. LaPrade's work really detailed its anatomy, moving us away from that vague term, arcuate ligament complex.
Right. Calling it the arcuate complex was a disservice. The clinical consequence of missing a PFL injury is chronic, debilitating rotational instability. The PFL is the primary restraint to external rotation.
So if you reconstruct the LCL for varus stability, but you miss the PFL tear,
the patient will continue to have a positive dial test. They will continue to have that rotational instability, especially at 30 degrees. The PFL is the rotational anchor of the PLC. You cannot ignore it.
So on both sides, medial and lateral, it's about recognizing that rotational stability and translational stability are often controlled by different structures.
An accurate classification means identifying and naming both failures.
Okay, we've mapped the hardware. Now we have to agree on the language to describe the mechanical failure. Noyes was adamant about this. Without a standard lexicon, the whole system just collapses.
It's chaos. We need precision in 3 areas: position, motion, and the severity of the injury.
Starting with position. That's pretty straightforward, right? Dislocation versus subluxation.
Right. Complete separation versus partial. Then there's motion, described in those 6 degrees of freedom. And this is where we get into the reality of coupled displacement.
Yes, the classic example. You apply an anterior load to the tibia, and it doesn't just slide forward, it also rotates internally. Why does it do that?
It's a beautiful anatomical response. It happens because when the ACL is gone, the lateral structures, the LCL, the lateral capsule, they act like a tether or a fulcrum. The medial side is often a bit looser, so as the tibia slides forward, it's forced to pivot, to rotate internally around that tight lateral complex.
So if you only measure the forward movement and you miss the rotation, you've misclassified the injury.
You've missed half the problem. Which brings us to that critical distinction you have to drill into every resident: laxity versus instability.
Right, laxity is just looseness. It could be normal.
Some people are just hyperlax. Instability is the pathology. It's the excessive displacement from an injury. And we have to quantify it in millimeters of translation, degrees of rotation, and always, always compare it to the other uninvolved knee.
And for severity, we still use the basic sprain grades, but that third-degree sprain needs to be broken down further.
It does. First degree is microscopic. Second degree is a partial tear with some abnormal motion. Third degree is a complete tear, what we call demonstrable instability. But for a ligament like the MCL, we have to subdivide that third degree based on how much the joint opens on a stress test. Is it less than half a centimeter? Is it between half and 1? Or is it more than a centimeter?
And Noyes also had a really important point about what defines a rupture from a surgeon's perspective. It's not just about seeing a tear.
No. A rupture implies a complete tear and a complete loss of function. Function being the ability to resist displacement. You can have some fibers that are still visually connected, but if that ligament has a soft, mushy endpoint, if it can't do its job, it is functionally ruptured.
This all sets the stage for the big historical debate, right?
Yeah.
The classification wars. Houston versus Noyes and Grude.
It was a huge philosophical shift. Houston's system is wonderfully intuitive. It's very mechanical. He based everything on the status of that central pillar, the PCL.
So for him, rotatory instability is what happens when the PCL is intact.
Exactly. The tibia and femur rotate around that intact PCL like a central post. The classic example being anterolateral rotatory instability, or ALRI.
That's the pivot shift. Excessive internal tibial rotation and anterior subluxation.
Yeah.
So structurally, that means the ACL is gone.
The ACL, the lateral capsule, and usually the LCL and PFL. It's a major disruption. And the clinical pearl, the one thing you have to remember, is the second fracture. If you see that little avulsion fracture on an X-ray, it is pathognomonic for ALRI with an ACL tear.
And the opposite is posterolateral rotatory instability, PLRI. The lateral tibial plateau rotates backward, again with an intact PCL acting as the axis.
Right. Here the tears are in the posterolateral corner structures, the PFL, the popliteus, the LCL.
So if rotatory instability is with a PCL intact knee, then straight instability for Houston meant the PCL was torn.
Yes. For him, straight instability was pure translation without rotation, hinging on an intact collateral. But this is where the conflict was. Houston did not believe an isolated ACL tear could cause straight anterior instability.
Wait, that contradicts almost everything we see now. Why did he believe that?
From a purely mechanical perspective, he argued that for the tibia to slide straight forward without rotating, the displacement had to be so large that it was impossible without also tearing the PCL or the collaterals. He felt an isolated ACL tear could only produce rotatory instability.
And that's the limitation that Noyes and Grude seized on.
That's it. They said Houston's terms were imprecise. They wanted to move from description to objective measurement. They introduced what they called the bumper model.
The bumper model.
Imagine the tibia sliding forward. It eventually runs into bumpers, the secondary restraints like the menisci, the capsule, the other ligaments. Their model forces you to quantify exactly how much translation and rotation is happening, not just give it a label.
And that led to their classification of anterior subluxation types, which had real prognostic value.
Yes. For instance, a type 2 subluxation. That's what you want to see. The ACL is gone, but the extra-articular structures are still tight. The bumpers are good. That patient has a much better prognosis after reconstruction.
Whereas a type 4, that's a total failure of the system.
Catastrophic failure, gross subluxation of both the medial and lateral compartments. That tells you immediately that there's major associated damage to the lateral side, maybe the medial side too. If you see that, you can't just fix the ACL. You have to reconstruct the entire bumper system.
So it's a philosophical shift.
Yeah.
Houston gave us the mechanism, Noyes and Grude gave us the metrics.
Exactly. They forced us to look at the whole picture.
Okay, so let's bring this into the clinic. Our clinical exam has to reflect all this biomechanical pathology.
It has to. And it starts with the collateral test. Take the valgus stress test. The key is the position of the knee.
Right. At 30 degrees of flexion, you're isolating the MCL.
You're isolating it, but if you test that same knee in full extension and it still opens up, now you're involving not just the MCL, but the posteromedial capsule and the PCL.
So if it opens the same at 0 and 30 degrees, that's a huge red flag for a combined injury.
Massive. It's the same logic for the varus stress test. At 30 degrees, you're testing the LCL. In full extension, you're testing the LCL and the PLC and the PCL. You have to test in both positions.
Moving to the cruciates. The Ligament test is still the gold standard for the ACL. And it's not just about how much it moves.
It's about the endpoint, the quality of the endpoint. A soft, mushy endpoint, even with minimal movement, confirms a rupture. I remember a case, a huge college football player, his hamstrings were so strong you could barely get any drawer. But the Ligament, there was no endpoint, just mush. That's a functional grade 3 tear.
Which is why the dynamic tests are so powerful. The pivot shift test.
The pivot shift and the lose test. They recreate the instability. You're actually demonstrating the subluxation and then the reduction of the tibia. That palpable, sometimes audible clunk, that's the feeling the athlete hates, and it's definitive for us.
All right, and for the PCL and PLC, the posterior drawer test is the standard, but we have to watch out for that critical pitfall.
The posterior sag, you have to avoid it. If the PCL has been out for a while, the tibia is already sitting posteriorly. If you just pull forward from there, you might only bring it to neutral and think it's stable. A massive false negative.
You have to lift it to neutral first.
Always. Which is why the quadriceps active test is so good. It's highly accurate. You have the knee at 90 degrees, the tibia is sagging back, and you just ask the patient to gently contract their quad. The quad will pull the tibia forward, reducing the subluxation. It's elegant.
And to differentiate that posterolateral corner injury, the dial test is the one.
It is non-negotiable. You do it with the patient prone, and you measure external rotation at 2 angles, 30 degrees and 90 degrees.
And the comparison tells the story. Increased rotation at 30 degrees, but not at 90.
That's an isolated PLC injury. The PCL is still doing its job at 90 degrees.
But if you see increased external rotation at both 30 and 90 degrees...
Now you know the PCL has also failed. It's a combined PCL and PLC injury. That simple test gives you so much information for accurate classification and surgical planning.
Okay, so we've got the hands-on exam, but the whole push for standardization really led to instrumented testing, right? You get objective numbers.
It was the next logical step. And the most established device for that is the KT1000 arthrometer.
It measures anteroposterior displacement, and Daniel's work really established the benchmark for it.
He did. He showed that a side-to-side difference of 3 millimeters or more on the manual max test is highly, highly indicative of an ACL rupture. We're talking 97% accuracy. It's reliable.
But it has one major limitation.
A huge one. It only measures AP translation. It can't tell you anything about rotational instability or varus valgus laxity. That's why even with all our tech, you still need your hands. The KT1000 only measures 1 of the 6 degrees of freedom.
So beyond the objective laxity, we need the rating systems to connect that to the patient's actual function.
Exactly. You have the Ligament scale, which is purely subjective. Pain, locking, instability. It's a quick snapshot of how the patient feels.
Then the Tegner activity scale, which is about what they can do. Are there a level 10 competitive soccer player or a level 4 recreational skier?
Right. It defines the functional goal. And then you had attempts to combine the two, like the Cincinnati knee rating system, which brought in subjective scores, objective exam findings, KT1000 data, and x-rays.
But the undisputed global standard now is the International Knee Documentation Committee form. the IKDC.
The IKDC is non-negotiable for any kind of standardized reporting. It looks at everything: symptoms, motion, ligament, exam, atrophy, everything. But the most crucial rule, the thing we have to internalize about the IKDC, is that the worst group determines the final evaluation.
That has huge implications. So you could have a patient who feels great, scores excellent on their Lysholm, but their KT-1000 shows more than a 10-millimeter difference.
And their final IKDC grade immediately drops to severely abnormal. It creates a real counseling challenge. The patient says, "But doc, I feel fine."
Right.
And you have to explain that the system is designed to identify objective risk, even if they feel subjectively recovered. The IKDC forces you to be rigorously honest. It forces you to address every single component of instability.
It's protecting the patient from themselves, really,
Right.
preventing them from going back too early and blowing up their cartilage.
That's a perfect way to put it. So this whole deep dive, from Houston's mechanical models to the quantitative demands of noise, it all comes down to this. We need a system that's objective and comprehensive.
We've charted this whole evolution of thought, and it's clear how much we've progressed.
And remembering those key technical figures, the PCL being nearly twice as strong as the ACL, or the PFL being the critical restraint to external rotation, that's the foundational knowledge that lets us make good decisions in the OR.
But I keep coming back to that one fascinating detail we mentioned earlier. We know the PCL is this central, powerful axis, provides 95% of posterior stability. Yet we also noted that patients with isolated PCL tears can maintain surprisingly good function.
They can.
And that just raises this really provocative question for us.
It should. If that massive static stabilizer is gone, but the patient is still functioning reasonably well, what does that tell you about the power of the dynamic stabilizers, the muscles?
Exactly. The semimembranosus, the gastrocnemius heads.
They are powerful dynamic posterior stabilizers. Their compensatory capability is remarkable.
We spend so much time and effort trying to perfectly replicate the static anatomy with our reconstructions. But should we also be classifying the efficacy of the remaining dynamic structures? If the muscles can compensate for a total PCL tear, could we improve outcomes by focusing more on maximizing that dynamic stability?
That is the perpetual learning curve, isn't it? Perhaps the next generation of classification systems won't just grade the static anatomical deficit. Maybe they'll also quantify the patient's dynamic capacity, their potential for muscular adaptation. We measure the static failure, but maybe we need to start measuring the dynamic function.
Perfect place to end. Thank you for guiding us through this. This has been an incredibly detailed and important deep dive.